July 2022, and we are here talking to Jonathan Ramsay, urologist, who has very kindly come today, and he's going to answer loads of questions from the community, but he's also going to give us a presentation on varicocele, because that's something I know we all struggle with, getting some homogeneity from the people we send our clients to about. So we're going to just kick it off with the full spectrum of the questions we've been asked and then move on with the time we have. We're finishing at 11:30 today, so just so you know where the cutoff is. All right, good morning, and thank you for coming. We're going to start with a question. Is the ROS test better option than the Comet because it's cheaper?
So that's a good question, and I'm not using that phrase, like the politicians, meaning that's a good question which I can't answer. It's actually a good question because the reactive oxygen species level in seminal plasma is, of course, the principal cause of sperm DNA damage. So you could say that it is a surrogate marker for DNA damage. And one of the big fertility providers has taken this view, so that you will see many clients, and I'm beginning to see patients who have had a reactive oxygen species test instead of a DNA fragmentation test. Now, the rationale for doing this is that, first of all, it might be, not always, but it might be a marker of DNA damage. And of course, it's not expensive and easy to perform. So we have to put ourselves into the mindset of an IVF clinic. So if they can do, as they always do, a semen analysis, and they can take some of the seminal fluid and put it into a little machine, which is not very big, and get an answer or a level of reactive oxygen species, a measurement of oxidative stress. And if they then assume that that is a possible cause of DNA fragmentation, they then take quite a big step and omit the DNA fragmentation. And they will say, okay, so you've got raised oxidative stress. That's not good for sperm. Let's give you 3 or 4 months of antioxidant treatment. And that bit is sensible, because it's actually much more sensible to use antioxidants when you know their high levels of oxidation. And then they say, you, the man, will probably have better quality sperm, and therefore we needn't do the DNA fragmentation. So is it as good as actually knowing what the DNA fragmentation is? No, it isn't, because you may have high DNA fragmentation independently of high levels of reactive oxygen species. So in my practice, I would always do both. But I think one must not, people like me certainly must not be too hard on the IVF units. Far better that they should be doing something and measuring something and then reacting to what they found than not at all. This is a much better situation than what we used to hear a few years ago, and what we still hear sometimes, which is, don't worry, ICSI will sort it out. So we're one stage further on. And my own prediction would be that they will do this for some time. Again, better than nothing. And then in a couple of years, 3 years' time, they might be thinking, yeah, we need to see the DNA fragmentation as well.
Thank you. That's really useful. That independence of markers, that you can have a normal ROS and an abnormal DNA fragmentation, is really important to understand.
Yeah, and also there's the measurement of reactive oxygen species comes in different forms. So I think what you're referring to, because this is the practice I was describing now in clinics, is a myoxis measurement. And that measures the reduction oxidation capacity. So it's not quite the same as a reactive oxygen species test that looks at the oxidizing substances stuck onto the sperm head. So in many ways, it's a simpler test to do. In some ways, it can be a more useful test. But at the same time, you do have to calculate it. And to a certain extent, the result is dependent upon the number of sperm.
Oh.
So there is a calculation to be done. So occasionally, particularly with low sperm counts, that number might be erroneous.
Mm.
And of course, like all of these tests, which are both qualitative and quantitative, one has to see a lot of them and relate those tests to other investigations, particularly, I would suggest, DNA fragmentation, to begin to understand the validity of that particular test.
Mm.
So it is not, just like semen analysis itself, these are not absolutes. It is not the case, as we all know, that because you have a semen analysis that shows 1% normal sperm on, Thursday, the 22nd of July, that some other seminologist or andrologist won't find 2 or 3% next week. So we do tend, and of course you all know that men tend to read their semen analysis as if it was a bank statement, as if it was absolute truth, real time, like going to the cash point. But we all know that this is a biological system and it's variable. So I think, as with all tests, familiarity, being able to look at all the results together, if we do that, then we all begin to learn a bit more.
I'm always fascinated by the fact that women are examined in the round, blood tests, scans, internal examinations, but men are given this one semen analysis and extrapolate everything from that. And whereas there's so much more to the spectrum of male health that is unexamined. So next question. We recently had a case with excess disomy of sex chromosomes. When would this be suspected? What is the test that determines this and what can be done about it? In this case, there were a set of 6 frozen embryos. On further testing, only one of those embryos was euploid. Most of the cells had no DNA in them. Does that mean the euploid embryo has not been affected by the excess disomy of sex chromosome issue?
Okay, so the final point there was that 1 out of 6 embryos that were PGTA tested or screened was euploid, i.e. a normal chromosome complement. So the straightforward answer to the end point of that question, which was, can we trust that euploid embryo, is yes. The secondary implication of the question is that the other 5 aneuploid embryos were as a result of the excess number of sperm which were carrying the disomy, so an abnormal chromosome load. Now that may not be true at all, because it is very important in such a question actually to know the female status and particularly her age, because it is more likely that, as happens as egg quality deteriorates, that the 5 aneuploid embryos related much more to egg quality than to the disomy in the sperm.
So, for example, as a hypothetical situation, if we were to take a donor egg, a 20-year-old's egg, under the circumstances of having that excess disomy, would that overcome some of the issues that we may be seeing in an older woman?
The answer is it may well do. But of course, disomy is, like so many of the genetic tests, it is both qualitative and quantitative. So when you look at sperm aneuploidy, and disomy is one of the aneuploid forms, then this will be reported as an excess number of sperm, which may be more than 1 or 2%. So not many, which carry this abnormality. Now, so it is too simplistic to say, okay, if it's not one of those sperm, then it will work. Because the abnormality of the chromosome makeup in a sperm may actually underlie other defects of sperm production. So that a man who has a higher percentage of aneuploid sperm than he should have, so he may be up to 3 or 4% aneuploid sperm, even 2 or 3%, then this may be a sign that all is not well, quite apart from that finding in the factories.
Okay.
So it is not as simple as to say, well, if it hasn't got, the embryo hasn't got the abnormality that we found in the sperm, it's okay.
So circling back to the beginning of that question, when would you suspect that needed to be something that was tested for? Is there anything overt that would make you suspect?
No, I think sperm aneuploidy is something that in my practice I will do when I have exhausted all other possibilities and obvious causes of usually not just failed cycles of IVF and ICSI, but unexpectedly bad results. So it's not something that one does very frequently. Interestingly, of course, if you look at the genetics of male subfertility and infertility, and you look at all the abnormalities in research terms that have been found that cause failures of the process of meiosis, then actually at the moment there are 100 identifiable abnormalities. Now, not all of these, of course, are going to result inevitably in failures of IVF and ICSI, but they do give us insight into the reasons for the failed process of spermatogenesis.
Okay. And a test for this would be just a normal semen analysis, sample can be given and a test can be done.
Aneuploidy looks at some headline abnormalities, some headline chromosomal abnormalities.
Like not all of those 100 obvious.
No, absolutely not. Absolutely not.
Okay. So we've been hearing a lot about Zymot lately. I had a very long conversation with the head embryologist of Eve Rock Christian, who's very passionate about this. And he was talking about the fact that they do, without the label of Zymot, they do a similar thing whereby they just don't centrifuge a swim up and are able to achieve the same results. Do you have any thoughts about how useful it is, the applicability?
So the Zymot chamber is like an assault course for sperm. And the theory is that only the better sperm, particularly those carrying better DNA, will get through this microfluidic chamber or micro assault course. And to a certain extent, that is true. So if you try to measure the DNA fragmentation of the sperm that have got to the other side, then usually you will find indeed that it is better. But of course, what it is also doing is selecting a different population of sperm, so that sometimes you get surprising results. And so on the other side of the Zymot, the DNA fragmentation is actually worse.
Oh, interesting.
So it's not necessarily a panacea. And you do require quite a lot of strong motile sperm to actually get to the other side. So the Zymot is attractive, again, a bit like doing the ROS test and not the DNA fragmentation. The ROS test, the Zymot is attractive because this is something that can be easily used in a laboratory. And where it started, interestingly, was in IUI cycles. Now, of course, in IUI cycles, almost by definition, there's a higher motile sperm count. So the efficacy of the Zymot may well have been better and therefore did add clinical efficacy to IUI. Now, whether it will prove to add clinical efficacy to ICSI cycles I think has yet to be proven. It's a very attractive idea. It's a very simple idea, and it's something that is relatively easy to do. But we do have to remember, if you can visualize it, that this is more stages of messing about with a sperm sample that almost by definition is inadequate. So we do have to be careful with the laboratory add-ons.
Okay.
They are not a panacea.
And over the years, we've seen so many things like sperm glue go out of fashion, or sorry, embryo glue go out of fashion. They come and go add-ons, right? And it takes a little while to see whether it's there to stay and useful.
Sure. I think one can say, if you look at the PIXs, the PIMSs, the EMSs, calcium ionophore slightly different, but if you look at all of those add-ons, they certainly do, in certain circumstances, improve live birth rates where previously there were very poor outcomes. But to put a percentage uplift, a real percentage uplift, it is an extremely difficult thing to do. And that is the trouble with the whole of our subject, because we often hear, doctors particularly, talking about the evidence base. Well, we can get data, we can get oceans of data from fertility units, how many eggs, how many fertilized, how many blastocysts, pregnancy rate, miscarriage rate. Once one starts looking at live births, however, this becomes very difficult. It becomes very difficult because of data collection. The bigger the unit, the wider the pool of patients. So some of the patients may have disappeared or gone away or moved, and you can't track them. And if you're looking for what is inevitably a small percentage uplift in live birth rate in 1,000 cycles, it doesn't take many bits of lost data to make that data invalid. And therefore, that data, which is often presented as evidence because there were 1,000 couples, actually maybe because it was just a little bit incomplete, it's a little bit wrong. And if you're trying to tell the difference between a 3% uplift in live birth rate and a 5%, this is really difficult to do. Really difficult to do. And of course, the couples, as we know, are not homogeneous. And so if you try to match them retrospectively for age, for the number of eggs, for antral follicle count, this becomes almost impossible. And then so the evidence mongers say, well, we want a randomized prospective trial, because that's the only way you get statistical power. But we know from our patients, you can't say to the patients, look, I've got a great idea. We're going to randomize you to PIXI or Zymot, and you come to see me for my opinion, and I'm just going to toss a coin and say PIXI or Zymot. Well, that's not going to work, because nobody's going to say yes. So to get evidence, you need a prospective randomized trial comparing two things. And probably, because the only thing we do know is that ICSI produces a certain proportion of live births, and probably you need a third arm, standard ICSI, PIXI, Zymot, 1,000 couples each. Well, that's not easy. So I hope that answers it.
Yeah, I think it does. We have a question about what supplements would you recommend to improve sperm? Is there a brand or main recommendations, or do you just tend to send?
I work, as you know, with nutritionists.
Yes, so you're happy to outsource.
Because generally speaking, I spend maybe 45 minutes with a couple on the medical and technical issues. And in the 44th minute, they'll say, now I've just got this list of 14 supplements. I wonder if you could just run through them. So, and at that point, not only do the clinicians lose the will to live, but actually you sort of run out of steam. And though you could write a book about useful, less useful, and very interesting supplements, I do tend to leave it to the nutritionists, whom I trust.
Yes, absolutely. So we have a question, I think this is from someone who's not in London. How can we encourage clients to explore urology to improve sperm health when the IVF clinics say ICSI will fix it? It can be a very difficult conversation when our advice is the polar opposite of the IVF consultant's position.
Sure. Okay, so this is a perennial problem. So the ICSI will fix it statement, made in good faith by many of our colleagues, actually, of course, principally gynecologists, but also urologists. Now, the first thing to say about that statement is that it's easy to say, and in 30% of cases, it's true. So it's not that it's an untruth. But the other thing about that statement, of course, is it is what the couple wants to hear. Just like they might want to hear, oh, Zymod will fix it. Oh, Proxy will fix it. They want to hear that something's going to fix it. So whoever makes that statement, ICSI will fix it, knows that they are pushing against an open door for a cycle of ICSI. And that we do have to see it from the other point of view, which is that if you start saying, right, this is silly, you've got awful sperm, you've got a dreadful diet, awful lifestyle, and as my dear friend Cheryl Homer put it, why would you try and run a marathon without doing any training? Now, because if you say that, then particularly she is going to be a bit upset. He might be a bit resistant too. So, of course, it's different when we're into our third and fourth cycle, when quite clearly ICSI hasn't fixed it. So we're now pushing against an open door to try and make it better. So from one point of view, that's, I think, probably everybody listening and me, Naava, of course we would say, let's just make this better before we start. But we don't actually see that number of people before they start. We're seeing a different cohort, and there's a cohort of people who, when they fail, they've come to see us. So of course, we're getting a different question. The question that the gynecologist is getting up front is, I want a baby and I want one next week. When can I have the cycle of ICSI? So for he or she to say, well, actually, we're going to wait for 3 or 4 months, it doesn't play well. So I do have sympathy with that, whilst I entirely agree that if you're going to have an intervention which is more likely to fail than succeed, let's try and get everything lined up before we do it. But the contrary argument to that is, from many fertility units, will be, okay, chum, smartass, you give us the evidence that says that if we do all this intervention before a single cycle of ICSI, the live birth rate goes from 30 to 50%. Well, of course, we can't do that because nobody's ever done it. And part of the reason nobody's ever done it is because it's very difficult to do. It's the flick of the coin. Tell you what, you lot heads, you're going to wait for 4 months, 5 months. We're going to make it better. And the other lot can, yes, have it next week. So this is not as, whilst I agree with the sentiment of that question, I think it deserves a bit of explanation.
Yeah. Okay. spent an afternoon inhaling Professor Shanna Swan's book, Countdown. I'm not sure if you've read that. It's a fascinating book looking at epigenetics of sperm and really talking about.
Oh, yes. Yes, I didn't hear the thing, yes.
Yes.
Absolutely.
And so after having read that, I think that the place that for so many of us have in the alternative medicine world now, the place for professionals like you have, is this education piece, which is missing. That is that common sense about the healthier you are, the healthier
Sure.
your children will be, your grandchildren will be. And so there's this place for us to do our work. And even if it is off the back of an unsuccessful cycle, at least there is a place for people to go now that they may not have been before.
You have a far better chance of trying to get it right, paradoxically, after it's failed. That's the great paradox about what we do.
That's certainly my experience. Thank you. Okay. So what are the key things to pick up in a semen analysis that should prompt a referral to you? I know about count, motility, and morphology, but what about debris, color, and high pH? For example, I have a new client with a pH of 9 who's been told that's fine by his clinic.
Sure. Well, so this is the abnormal seminal fluid, really. This is looking for other factors. This is the science of sperm gazing, because we have to remember, before there was ROS, before there was DNA fragmentation, even before there was ultrasound. So if we go back to the 80s, when Bob Winston and others and Bourne Hall were starting IVF and ICSI, one of the things that happened was that purely looking at the semen analysis gave extra information when there was none other to have. And therefore, very high pH, the presence of debris, the presence of clumping, all of these physical features were studied. Now, do they matter of themselves before ICSI? No. But might they be a sign of something else, like an inflammatory process? Yes, they may be. So if we are struggling and we're looking for a reason to be struggling, and the semen analysis itself is not, that is to say, we are in the territory of unexplained infertility, then of course the high pH, presence of cells, debris, this may be associated with an inflammatory genital tract condition, which one should then look for.
And that's when semen culture comes into play.
Yes, and probably more subtle, I hope, measurements of the seminal plasma microbiome.
Ah, where is that done?
So, well, it's done in research. So there's been some interesting research published from Imperial and Hammersmith, where, of course, I only very recently retired from. But there are just around about the place, different parts of the world, ways of looking at the seminal plasma microbiome by PCR, by a technique that doesn't culture.
That's fascinating. We spend so much time with women looking at the gastrointestinal and particularly the vaginal microbiome, and we see the impact that has. So it's fascinating to hear that that's where this is going. Is this something you order? Is this something you routinely do?
So it's something that I hope contemporaneously as we speak is being developed.
Oh, wow.
At the moment, I tend to use, one does what one can with culture. Trouble with culture, of course, of sperm, and culture of anything, is that traditional culture methods require a lot of organisms of one type to grow through on the culture plate. And it may also be extremely difficult to grow organisms that are called fastidious. So they require very particular circumstances. For example, no oxygen. They may be anaerobic organisms. So by old-fashioned culture, just like Fleming and penicillin and Petri dishes, old-fashioned culture will miss all but florid infections and large numbers of organisms. And even then, when you find Enterococcus faecalis, which you often do, the men may have and usually have no symptoms at all. So doesn't quite fall into the traditional medical definition of infection, but the presence of microorganisms without symptoms, of course, can be a much more subtle effect.
All that inflammatory process.
All the inflammatory processes. So standard culture doesn't pick up everything. And then PCR of the urine only picks up headline organisms, the chlamydia, the mycoplasma, the ureaplasma. And so we cannot identify the range of organisms that would be typical in a vaginal microbiome. So in my practice at the moment, although I will culture the sperm and do a PCR of the urine, I will often use the results of a vaginal microbiome as a surrogate for what the man may have.
Yeah, so you dose the couple off the back of that. So that's interesting. So we, in fact, I often will send, in fact, most of the time I'm sending clients to with the semen analysis and a DNA fragmentation test, and I send them to you for culture, a varicocele check and so on, but perhaps now I should also be sending the vaginal microbiome results too.
Sure.
That would be very good.
Sure. Now, of course, the microbiome, so if there are two words in the scientific community that drive proper scientists, of which I am not one, bonkers, the two words are microbiome and epigenetic. Okay. So, because the scientists will say, all this microbiome malarkey, they'll say, and malarkey is not inappropriate word because an awful lot of it comes from Cork in Southern Ireland. They'll say all this microbiome malarkey is interesting, of course, but it doesn't represent illness. It doesn't represent an infection that we can identify. They will say it is we accept that you can have a dysbiosis, so an imbalance of organisms, but we are yet to be convinced that this is irrelevant. Okay, that's because scientifically, it's really difficult to match a particular dysbiosis to a particular outcome. So I'm sympathetic with that. With epigenetics, they say, oh, well, show me the gene. You know, you say there's an epigenetic phenomenon here that damages genes, but which gene? Where is it? You know, you come up with a damaged gene, they say, you know, smart ass, and we'll believe your epigenetics. And microbiome, to a certain extent, scientifically falls into that category. And once again, it's a bit like the whole of our specialty. To match a particular dysbiosis of the vagina to a particular outcome is very difficult. So we've got a problem with credulity here. But of course, first principles imply that if there is dysbiosis in the vagina with the same sort of organisms that could, if they were more numerous, give you bacterial vaginosis, then it isn't a giant leap forward to say this could be affecting the endometrium. Now, of course, the studies that have been done trying to relate the vaginal microbiome to the endometrial microbiome, the ALICE and the EMMA test, are inconclusive. And even the studies that were done in Warwick University looking at the relationship of positive ALICE and EMMA tests, so endometrial specimens, to outcome, recurrent pregnancy loss, for example, are again very, very difficult to prove. But if you stand back from this, so you ignore science, ignore evidence, and you say to yourself, right, there's dysbiosis in the vagina. We know there are presence of organisms in the male genital tract. And this couple have suffered recurrent pregnancy loss. We see that often. Now, you could, on the one hand, say, well, these are shared organisms between the vagina and the genital tract. And we know that that degree of inflammation might be damaging the DNA in the sperm. So it could be that. But it could also be that this shared problem is having a marginal influence on the state of the endometrium. So that this would not be unusual, in the panoply of medicine. Organisms out of balance cause an inflammatory response. Inflammatory responses generally, about end up in diseases. It all starts with inflammation. So on a rather facile level, and I know I am being facile to a certain extent, I am a bit facile, it strikes me as being likely, though very difficult to prove. And so when you have a circumstance like this, you have to say to yourselves, I must be very careful not to tell the patients that what I think is a medical truth, that what I think is an established fact. Because there is a huge difference between what we think, then the data, which is what we use to base our thought process, but we have to admit that there is a total lack of evidence. Of course, if you conduct your professional life purely driven by evidence in a subject where you cannot randomly, prospectively study the cases, then you're never going to move forward. So we do have to be careful not to step too far out of the box, not to become fantastical and then be accused of mythical thinking. This is the reason this subject is so fascinating, is because of all of this.
Okay. So we're going to move to a completely different topic, just briefly, which is question, is a recent bout of COVID a reason to delay IVF? And if so, how long should we recommend they wait?
Okay. So at a simplistic level again, the answer to your question is almost certainly yes. And there are two reasons for that. The first is, if you like, an academic, scientific, i.e. knowledge-based reason, which is that COVID does or can affect sperm production and sperm quality. So we know that it can get the virus, depending slightly upon what strain, can get into the testicles. Now, how often does that actually happen? Nobody really knows, but the fact that it can do it should be enough to send a big warning sign. Now, the second issue is that the response to the COVID virus is very variable. Mostly, of course, the men do get a fever. They deny it. They even deny they've had COVID until their wives say, oh, but come on, look, do you remember, January the 22nd, you were as sick as a parrot? And he says, well, only for a couple of days. And she says, yeah, but you've got a fever of 39-40, for 2 or 3 days. So the second issue about COVID is that, like any other major inflammatory response, there could be an acute effect purely due to the inflammatory response, independent or compounded by the fact that the virus may or may not be in the testicles. So in terms of knowledge base, there is every reason to delay. On a human level, although they want to do it and they're set up to do it, on a human level, again, this is the psychology of IVF, desperate to do it, doesn't work, then what did we do wrong? Could it have been the COVID? Shouldn't they have told us to delay? So on a human level, I think there is a reason. Of course, if it works, fine. If it works, well, then we'll never see them again anyway. But it's when it doesn't work, this could be a cause of recrimination. No, I'm not talking about recrimination to the doctors and lawyers and suing. I'm talking about the human business of recrimination between a couple, if only we'd waited. So I think there is every reason, probably on every level, to delay.
And when you delay it the full, let's say 100 days, so the cycle of sperm is
I think it's got to be 3 months.
probably 3 months. Okay. Thank you. At what point would you recommend karyotyping?
Okay, so the question is when would you recommend karyotyping? So I think in every azoospermic man, without a doubt, and in every man whose sperm count is persistently under 5 million. Now, if you want to catch every single genetic abnormality, chromosomal abnormality that could be associated with male infertility, then you'd make a much higher cutoff of 10 million, persistently under 10 million. And of course, we're looking at a headline thing here with karyotype.
Yeah.
But I've already mentioned that, you know, there are 100 candidates for the genetic abnormalities of the process of sperm making. And once we understand those, and we can actually easily measure them inexpensively, then I think we would be extending the range of genetic testing to patients with 10 million sperm. But at the moment, my level is 5.
And persistently 5, not just a one-off of 5?
Persistently
5. 2,
or less.
3?
Yeah, 5 or less.
Okay. As in 2 or 3 semen analysis before you would make that call.
But if they're azoospermic, and they really are azoospermic, they've got non-obstructive azoospermia, they must have a karyotype and a Y micro deletion.
And a Y chromosome deletion, did you say?
Yes, you're looking for the deletions of the Y chromosome in 3 separate sites. There's the A site, the B site, and the C site. And A and B, so if you have micro deletions of the Y chromosome at these sites named A and B, then the chance of a sperm retrieval is 0. At the C portion, that's not true. You may well find sperm, and some of these men do have sperm. So the 3 areas of deletion, A, B, C, and it's the C where we may succeed, the A and B we won't succeed. But in any case, doing this test, you give the man a reason, which is very important. You get the diagnosis.
Do SSRIs affect sperm? We've had a very conflicting
So
advice from that.
Do SSRIs affect sperm? Straightforward answer, yes. But of course, being utterly miserable, not sleeping, not eating, panic attacks, anxiety, feeling worthless, it is not a great state to be in if you're trying to start a family. So again, I think this is an area where one has to be sensitive to the man's requirements, the couple's requirements, because if again, you know, we're in a powerful position as people advising these desperate patients, and they are open to manipulation. And if you come in too stridently, saying, "Oh well, you know, here's a paper, there's a paper, SSRIs, sperm quality, sperm motility," the poor bloke, if he's not minded to stop them himself, his partner will stop him, and then he goes half bonkers. So I think one's got to be careful in managing, because we are managing a dangerous, difficult psychological state, and a difficult psychological interaction. And we must be sensitive to the fact that the man may already feel emasculated, which in some men may manifest as depression. And so there's a model that I talk about, which is the biopsychosocial, 3, like a Venn diagram, the biopsychosocial state that infertility inflicts on men and women, talking mostly about men here. The bio, because there's something biologically the matter. The social, because they get outcast. They're not like the other men with their 3 children, you know, strutting around. And then the psycho, because they feel emasculated, kind of inward looking. And if there is a past history of anxiety and depression, we must be very careful not to further destabilize this.
I like that diagram. It's a very interesting way of putting it, because we come up against that, us in our clinics, that we very rarely have men approaching us for care. It's usually discovered through the testing we do, through the partner, and then we have to nurture that side of things to be able. Thank you. All right. How many times would you re-prescribe antibiotics after a semen culture comes back with the same infection still present? How often do you see that?
So it's quite common. But of course, is it that you never treated it in the first place? Or is it a reinfection? Or did you treat it inappropriately? Or did you treat it, you thought you were treating it, and then actually disturbed further the microbiome to make reinfection more likely? So we really just don't understand. We're only in the nursery slopes of understanding about genital infection and its importance. And although I was going on about the microbiome and what a poisonous word that is to medical scientists often, not all, we don't really understand this until we understand what should be, in inverted commas, in the male genital tract, just like what should be in the vagina. And then when we understand whether there are natural variations, as there are in the vagina, during the menstrual cycle, the amount and nature of the lactobacilli shift. And the same may be true for men. So until we got a really clear picture about this, then we've got to be very careful with the antibiotics. These are broad spectrum, powerful drugs. And it's absolutely fine if you've got symptoms of urethritis, of prostatitis, and there's the germ, fine. Chuck the antibiotics around, try and get rid of it. And I suspect often in my urological practice, we might have got rid of one germ and replaced it with another, and that's why it's so difficult to treat prostatitis. But we must be jolly careful with this. So I hesitate to give the answer, repeated courses of antibiotics. And moreover, one has to be absolutely sure that this is relevant. Because if his DNA fragmentation is all right and the reactive oxygen species levels are all right, what are we doing?
Yeah, indeed.
We're treating a bit of paper.
Indeed.
Always a bad idea. Bits of paper don't get better.
Yeah. How often, so we had Cheryl Homer come talk to us, it was last year. She told us about PLC zeta. I'm wondering how often you have cause to do that test. It's very minute sort of
PLC zeta, I leave that to Cheryl.
Okay.
That is the intricacies of what I call spermology. This really is a laboratory. It's a fascinating issue, but it is not something that they used to do it at Oxford, where the research was done. But this is not something certainly that is in practice.
On a regular basis.
Yeah, and nowhere in London at the moment.
Yeah. Okay. Thank you. I was checking about that. All right. There's two more questions we have. I just had to go and fetch my phone to look at the time. So I'm going to leave one to the side because I think we've kind of answered it anyway, roundabout. But we wanted to ask about, there's passionate advocates for different kinds of DNA fragmentation tests. Cheryl Homer talked to us about the SCSA. We had Professor Lewis come talk to us about Comet. I spent quite a while talking at the fertility show, and I think he'll come and talk to us, the guy, his name's gone out of my head, but who's very passionate advocate for the tunnel. And then
Ralph Frankel.
That's the one.
Yeah.
And I'm wondering where you stand. How do you choose? Where do you recommend?
Sure.
What are the merits of one versus the other in your opinion?
Okay, but this is a little bit like brand loyalty in motor cars. You know,
That's a very good one.
I always drive a Volvo. I always drive a Volkswagen. I always drive a Mercedes. You can see I'm a urologist. So but it could have been a Prius, you know. But there is a loyalty. Now, why is that loyalty to the test? Well, it could be because that practitioner grew up with that test. It could be because that practitioner developed the test. It could be because that practitioner not only developed the test, but has a franchise on its use. So there are a lot of reasons for passion for the test that don't actually have anything to do with the merit or the demerit of the test. So it is a bit like motor cars. Is there one that's a bit better than the other, or a bit more expensive, or you get the results a bit faster, or is more consistent? I'm not sure that that's true. But what I do know is that it is difficult, if not impossible, to relate one normal number from, let us say, an SCSA to one normal number, let's say a comet. Partially, of course, because they're measuring different things, and the maths of the derision of the derivation of that number are different. So in the SCSA test, which is the one that Cheryl talked about, developed in America, very popular in North America. In the SCSA test, this is recorded, the numbers are recorded as an index, the DNA fragmentation index, the DFI. Now, of course, in the COMET test, then the headline number is an average. So immediately we have a different way of expressing a slightly different thing. Now, if you've been doing DNA fragmentation tests in thousands of people for 20 years, and you started off with the only test that was available in England, which is the SCSA, then you learned what that meant. But then when COMET came along, and the Lister Hospital in London adopted COMET about 7 or 8 years ago, then you began to be able to compare the two. And it became very evident to me that these numbers were different. So if you had a patient with unexplained infertility and a high COMET DNA fragmentation test, that's the gel electrophoresis way of doing it, examine, you had a high COMET which explained the unexplained, and you then did a bunch of treatments, and you then, because they're now not in the Lister, they're in central London, you then did what was the only test that was available outside the Lister, the SCSA. It was miraculously improved. But of course, we weren't comparing like with like. Everybody was delighted, but then they went and had another cycle of IVF and they got the same results. Had they had another COMET, it wouldn't have been that much better. So you've got to understand the difference and then familiarize yourself with that test. So that's gel electrophoresis and SCSA. Probably, crikey, worldwide, there may be more data about the SCSA because it was introduced commercially earlier. And it's done in a completely different way. The methodology, the equipment is different. But the protagonists will swear blind. Don Everson, the SCSA, Sheena, Examine, COMET, they will swear blind that this of course is the best test because it measures all kinds of fragmentation. Okay, so then we've got the tunnel. Now, if you look worldwide, then I think the tunnel probably has the edge for consistency. Worldwide. So you look at the big laboratories, which do a lot of male fertility work, then tunnel would be the most popular. Again, it works in a completely different way to both COMET and SCSA. But of course, there's no tunnel in the UK as yet. There will be. Cheryl's looking at some validation studies down in university, and Ralph Hankel is the tunnel man, and he's doing some studies at Imperial. So but then when tunnel comes and everybody says, oh, it's the best DNA fragmentation test, it will have different numbers again. So we'll have to get used to that. So if you come into tunnel fresh and you have the experience of doing it in 100, 150, 200 patients, the clinical experience, then of course you become a tunnel person, just like some people have become a comet person and some people have become an SCSA person. But speaking as a clinician, not a scientist, because all these people who are the protagonists are scientists, not clinicians. Speaking as a clinician, providing you understand how one relates to the other in terms of the numerics, then I don't think there's that much difference.
You've got to just pick your lane and stick to it long enough to be able to.
You need to understand what it is or it means.
Okay. Well, that brings us to the end of the question and answer period. Thank you. So just letting you know, we've got about half an hour. Are you comfortable picking up the highlights in your varicocele talk and walking us
I'll
through
run
that?
through it. Yeah.
Okay, I'm going to get that, share my screen and get that going for you all.
Okay. Good. Well, so now this is a presentation that I first gave to the Association of Biomedical Andrologists. So these were not a group of doctors, they were a group of scientists. They were a group of people who didn't examine patients or don't examine patients, what we urologists call a rummage in the scrotum was not something that they did. And so this presentation starts, and I thought it may be suitable for this audience, it starts with a pictorial representation of varicocele. And on the left of the screen, you can see the veins that are around the spermatic cord. At the bottom, you can see the testicle and the epididymis. And there are always veins around the spermatic cord. But if these veins enlarge, not dissimilar from varicose veins that you see in the back of the leg, if these veins enlarge, then they become, as it says, tortuous, lots of them, dilated. And in the most obvious cases of varicocele, you can actually see them. You can diagnose some varicoceles, at 5 yards with a man standing up, because just like varicose veins in the leg, when the man lies down, then the veins deflate because the blood flows back into the abdomen, and then there is no varicocele palpable. But when they stand up, either you can see them in florid cases, or you can certainly feel them. And classically, the medical students learn that a varicocele feels like a bag of worms. Now, it's usually on the left side, and you can see here the retroperitoneum, so that's the bit behind the peritoneal cavity, so all the bowel's been taken out, and you can see the aorta, the big inverted Y in red, and the vena cava in blue, and then you can see the two kidneys and the renal veins. Now, the reason that it's more common, or one of the reasons that it is more common on the left, is because the drainage of those veins, the spermatic vein, goes in a T-junction into the left renal vein. So there is a right angle between the renal vein, which is taking the blood into the vena cava and then on up to the heart, because all the blood is flowing upwards as you look at that diagram. But on the left side, the drainage is different. On the right side, you can see that the spermatic vein goes obliquely into the vena cava itself. And if you remember the physics, the Venturi effect, then if a side stream enters a big stream, then the flow in the big stream will tend to suck the blood out of the little stream. So if you think of a river and a tributary, and there's an acute angle of the tributary into the big river, and the flow in the big river will tend to suck the water out of the adjoining stream. But on the left side, that doesn't happen because it's a T-junction, it's a right angle, so that if the veins are not equipped with suitable valves, then the blood in the renal vein might actually impede the drainage, the flow from the pampiniform plexus, the veins around the spermatic cord, particularly on the left side, and then those veins dilate. So there is a difference anatomically between the two. And so I think this is really the point. I won't read the slide because that's a bit disingenuous, but there we have it. So does varicocele matter? Well, on that basis, and there is evidence, clear evidence, not just data, but evidence for those three statements and percentages, then you stand back from this and quite clearly it does matter. A more difficult question, of course, is in whom does it matter? In whom? In which of those 40%? Okay. So there we have it. And it's which ones matter. So all patients must be examined for varicocele. They must, because if they're with us, then they are the 40% who, and they're liable to be in the 40% who have varicocele. So we must examine them physically, not just because of the varicocele, as we will see, but because we need to grade the varicocele. And grade is about size. So we get more information from an ultrasound, which will measure the size of the veins. Now, a 2.6 millimeter cutoff is a pretty rigorous threshold. But certainly if the veins are 3 millimeters, then I think all the urological societies are now beginning to agree that 3 millimeters or more is relevant with reverse flow. So if you cast your mind back to the anatomical diagram, it's important that that blood, instead of flowing up from the testicle into the renal vein, into the vena cava and back to the heart, it's important that the blood flows backwards, because then it's hot blood from the abdominal cavity that is surrounding the testicle. And of course, the testicle enjoys, because it's inconveniently placed in the scrotum, it enjoys 3 degrees below core temperature. So if it's being bathed, the poor testicle, in blood that is flowing back from the abdominal cavity, then it will be the same as core temperature, and that's not good for spermatogenesis. So what does it do? Well, often we will see raised DNA fragmentation via, as we discussed earlier, the agency of oxidative stress. And there is an association of varicocele and antibodies. I suspect it's an association. Whether it's cause and effect is not entirely known. Now, some varicoceles, great big varicoceles, well, there may be a much smaller testicle on that side, and there is some evidence with a big varicocele on a small testicle that the varicocele may also actually alter testosterone levels. So now, how did we get ourselves into this muddle about whether it matters or not? Well, there's the history. So there was a bloke at the Walter Reed Army Hospital who spent his life doing ultrasound scans on young army recruits. And he was the guy who said it's 12.5%, maybe slightly higher than that, because of course he was to a certain extent looking at a selected group. And then in the 70s, before IVF and ICSI, we treated all the varicoceles in men with abnormal semen analyses and a failure of pregnancy. We just did it. So when I was a trainee, I hesitate to tell you all when that was, but it was sort of late 70s and throughout the 80s before IVF and ICSI. We would have, as urologists, we would operate on 2 or 3 varicoceles a week in a big teaching hospital for purposes of fertility. Now, of course, varicoceles, big varicoceles can hurt. And if they're achy, and they may be at the end of the day, then that still is a urological indication to treat them. But because I worked in a big center and we did a lot of fertility stuff, we were doing 2 or 3 varicoceles a week for infertility, for low semen analyses because that's all we could measure in those days. And then, of course, what happened in the 90s, the early 90s, was that ICSI started, and it seemed to be quite genuinely the solution. So men with low sperm counts, with virtually no sperm, were having babies for the very first time. And so, therefore, all the ladies who wanted to be pregnant, whether or not their husbands had a varicocele, became irrelevant, because they were just going to have ICSI, and hey presto, 30% of them got babies. So it came to be written that varicoceles clearly didn't matter because the solution was ICSI. But in any case, all the men with the varicoceles were banged up in the fertility units, so they weren't even seeing urologists. So we as urologists sort of got out of the way of doing this, except the very ancient old goats like me, who'd been doing it before ICSI anyway. So I never believed that this was not necessary. Now then, in the early 2000s, we, the medical profession, tried to address this problem by doing a meta-analysis, so, i.e. taking 1,000 publications, each of which had diddly squat patients in them. So you take the principle of a meta-analysis is you take all the publications, you add up all the patients in those publications, so that instead of reporting on 67, 123, 38, you are now reporting, you have a pool of clinical data relating to 3,500 people. And then you apply statistics to the whole group. And then you see if there's any difference between treatment and no treatment. So it is inevitably retrospective, but it is based upon the principle that you are upping the numbers, a meta-analysis. Well, of course, the trouble with that is that you have to make a very careful selection of all those papers to make sure that they are dealing with the same group of people. Because if you don't do a selection, a proper selection, which is called a systematic review of those papers, then you'll be trying to compare apples and oranges. You'll be putting them all in the same basket saying they're apples, but actually they're not. And that's what happened with that analysis. It just wasn't right. And if you revisit the papers that they looked at, and you only take out the ones that are homogeneous, that are comparing like with like, then you find a benefit to varicocele repair. And then in the 2010s, we begin to get guidelines. Now, so after the flawed meta-analysis, the American Association of Urologists and the European Association of Urologists began to change their tune. And the AUA says, treat the grade 2 and grade 3, but consider DNA fragmentation as an indicator. Now, that's what I think most of us who are specialists do. You measure the varicocele, a cutoff of 3 millimeters, raised DNA fragmentation, unexplained infertility. It's a slam dunk, treat the varicocele. Now, of course, the trouble is that NICE, so our, if you like, guideline controlling NHS body, that is the statement. I'm not quite sure if it's the statement this year, but it certainly was last year. So no evidence for treating varicocele. So in other words, they are repeating the mistakes of the meta-analysis. And of course, the consequence of that statement by NICE is that there's no point even examining the patients. But there's every point in examining the patients, because not only may you see the varicocele, as we see on the left there, but you may see other abnormalities that are highly relevant. You may see top left there that the man has had an orchidopexy, and so he's had an undescended testis moved into the scrotum, and you can see on his right side, or left as you look at it, that he's got a small testicle that's high riding. Why is that important? Well, it's a very common reason for oligospermia, and more importantly, men who've had undescended testes are more at risk of cancer. He may actually have a tumor of his testis, so we really, really ought to examine him. And he may have, as you can see top right on the left, a misplaced urethral opening known as a hypospadias, which is also associated with oligospermia and poor sperm production, probably some defects in the meiotic process in spermatogenesis. So physical examination is absolutely vital. And just to say, oh, well, varicocele doesn't matter, therefore you needn't bother with the bloke's testicles or his penis, it is actually tantamount to delinquent. On the right side, it's merely showing the sort of inflammatory processes that you can get of the scrotal skin, which of course increases temperature. Because as I mentioned, this is the whole point about varicocele. It's about temperature. We've already mentioned that it's about oxidative stress and it's about DNA damage, but the issue is temperature. And so this is merely just to re-emphasize that physical examination point. And actually to come back to some of the questions, I would never merely settle for measuring oxidative stress, the ROS test. I would always have it and a DNA fragmentation. As we've also discussed, I think the method of the DNA fragmentation matters less than the fact that you do it. What about treatment? Well, those are the treatment options. The embolization technique is one that I favor. It's minimally invasive, no cutting, no stitching, but you do have to have it done by an expert. Somebody who does loads of these things. And it's very important that the radiologist chooses his or her method of doing it. Either you can reach the internal spermatic vein, which you're going to block off by injecting a coil. You can either reach it from the right femoral vein. So you look at the right of the patient on that retroperitoneal diagram, and the embolization catheter goes into the contralateral, that is the right femoral vein. Then it travels up the right iliac vein, that is the right-hand side of the inverted blue Y. Then it goes up the vena cava, which is the straight blue bit. Then it turns right, as you look at it, into the left renal vein. And then it turns very sharp right into the spermatic vein, and then comes all the way down to the feeding veins of the varicocele in the left groin. Now, in order to traverse that journey with a little catheter, which is a plastic steerable tube, you have to be very skilled, because the other way to get to the left renal vein is straight through the jugular vein. Yeah, so it's a straight run, if you think about it, from the right side of your neck, yeah, into your vena cava and straight down the left iliac and to the internal spermatic vein. So there are two radiological approaches to this. For the patient, doing it from the groin is clearly much nicer because you're not being speared in the neck, like some radiological vampire. But it's much more difficult technically, as I've taken you through, to get your catheter to make your coil injection into the right place, because you've got to go all the way up, turn sharp right again. So it's a tricky. Now, subinguinal microscopic ligation is what is practiced by many urologists. It's a very good way of doing it. You have to be a skilled microsurgeon to do it. I used to do them all that way until I met a really good radiologist who is very slick and gets great results. If you look at the literature, overall, it'll say that the surgical approach is slightly better than the embolization approach. But then, of course, you'll find that those papers were written by surgeons, and mostly in North America. And one thing that is absolutely clear, that if you're a surgeon in North America, you won't get paid for recommending that your radiological colleague treats the varicocele. Okay, so we wrote actually now nearly 3 years ago, myself and you can see some friends from around about London and Kevin McElhaney from Newcastle, Mad Shabir from Guy's, Tet, Yap, Cheryl, and my friend Sux. So we put this together saying it's about time that the guidelines were changed. And what we said, these were our conclusions in that paper. And we thought in that paper that there was absolutely a case for repairing varicoceles as defined before assisted reproductive technology, failed IVF and ICSI. And we also thought that there was a developing case for treating varicoceles in non-obstructive azoospermia, but that's probably the most contentious.
And this is treating not grade 1, this is from grade 2 or 3.
2 or 3, so that we got to measure it, the 3 millimeters. Okay.
Is there some evidence to show that even grade 1 through treatment results in higher live
Got to
birth
be very
rates?
careful of that word evidence. I'm not sure there's
Read a
evidence.
paper.
Yeah, I'm not sure there's evidence.
Okay.
So we mustn't be, you see, we all the time, we mustn't be, what one's got to do is to look at all of this and then not be too prescriptive, and just to say, okay, so if there's a debate about varicocele, my feeling, whoever we are, the audience, my feeling is that there's something in this. The data is pointing towards treating the varicocele, certainly of 3 millimeters DNA fragmentation. But just because I think that, I've got to stop myself turning into a zealot and saying, if you've got a sniff of a varicocele, that's the answer. And we all have that tendency, Once we get the bit between our teeth, we sort of go for it. And then we turn into a fanatic. Yeah. And then of course we get sent to jail. So I'm a believer, and as you can see, these are my personal conclusions here. I would deal with I choose radiological embolization.
Can you say what cryptospermia is?
Oh, so cryptospermia is when you're only seeing sperm when you centrifuge it, and not every time. So the crypto bit means hidden. So when you just take some sperm, look down the microscope, there isn't any. You either look much more carefully or spin it down, you see some sperm. Okay. But cryptospermia, you see, when time allows, well, we've got some sperm. And if she's 38, 39, are we really going to give the 6 months necessary for the varicocele to improve it when we're not sure that it will? But if we've picked up cryptospermia and he's only 28, well, then one might, get some of that sperm frozen, do his varicocele, it'll probably be better.
How often in a year would you do sperm retrieval operations?
100.
So very often.
That's it.
Wonderful. And just in time, we're just coming to 11:20. You always threw that bang on. Thank you very much.
Good.
Does anyone have any further questions I want to put in the chat? We've got about 5 minutes left before we finish up today. Hang on. David is saying, hang on. Okay. In your experience, does finasteride have a long-term impact on sperm quality?
Straightforward answer, yes. So finasteride, marketed in 2 different ways. Firstly, for reducing the size, the volume of men's prostates, usually old men, and it's off patent now, but it used to be called Proscar. And then in a much smaller dose of the same drug, finasteride, sold as Propecia for male factor baldness. And it does work. Not that I've tried it, as you can probably tell, but men, young men, can become almost addicted to this because they've got a thing about their hair. Now, interestingly, usually the young men who are taking Propecia, as far as I can see, have got plenty of hair anyway, though my thresholds may be a bit different. But there are a group of men, and I'm sure a group of women, who have become a bit obsessed with their hair. And some of these guys have been taking quite high doses of Propecia for a long time, like 2-3 years. And then, of course, they do sort of become addicted to it because they become terrified that if they stop it, all their hair will fall out. But it certainly has an effect on the volume of the ejaculate because it shrinks the prostatic glands. And it has an effect upon the quality and the quantity of sperm. So it's a real thing. And it certainly take a year to get over the effects.
Oh, wow.
Maybe 2. And I'm not sure whether some men might be affected longer term if they've taken it for a very long time. But it's a real thing.
So it's quite a conversation that should be had before men are placed on that then.
Sure.
Yeah.
But again, it's the open door phenomenon. They want hair. They often want hair more than they think they want babies. They might want hair more than she wants a baby now. So the view is, well, let's do the hair now and the babies later.
Without a full understanding of the implications. Okay. All right then, thank you so much. Thank you for all your time and your wisdom. And I will, if with your permission, share that presentation so we can all have a copy and have a look over and have those figures to hand too.
Good.
Okay. Thank you very much.
Good. Thank you, Naava. I enjoyed it.
Pleasure. Nice to see you all. I'm going to
Bye-bye,
shut
everybody.
us down now. See you soon.